Hello, I'm Chris Bowlus, the Lena Valente Professor and Chief of Gastroenterology at the University of California, Davis in Sacramento, California. And today we're going to be talking about the current strategies, both pharmacologic and non-pharmacologic, for managing pruritus or itch in patients with primary biliary cholangitis or PBC. PBC is an autoimmune condition that affects the bile ducts of the liver. It's a chronic condition and leads to cholestasis and a common symptom of itch. Now, as physicians, we're frequently concerned about the progression of PBC in terms of liver disease, the development of advanced fibrosis, cirrhosis, and decompensation of cirrhosis requiring liver transplantation. When we think about PBC, we think about a rare disease affecting 1 in 10,000 persons maybe, but the people that are affected by PBC are primarily women over the age of 40. Approximately 80 to 90% of the people with PBC are women, but there does seem to be an increasing prevalence among men. Now, when you look at overall frequency of this disease in women over the age of 40, it's actually 1 in 1,000 that are affected with PBC. So within the demographic that's affected by PBC, this is actually a relatively common condition. However, when we think about PBC actually progressing to the need for liver transplantation, it's actually somewhat rare. Only approximately 200 transplants performed a year for PBC. Now, that means that as physicians, we need to not only think about the progression of the disease and slowing its progression with the tools we now have available, but also looking at the symptoms of PBC, which is something we often don't recognize. If you ask patients if they've been asked even about their symptoms, most will say that they've never been asked by their physicians about the symptoms of their PBC because we're often focused on that liver disease. The most common symptoms of PBC include fatigue and pruritus. The fatigue is a difficult symptom to address. We don't have a lot of tools for it. But the itch is something that affects about 80% of patients, and we do have lots of tools to manage that symptom. And by managing that symptom, we may actually improve some of the fatigue symptoms in those patients that aren't sleeping well because of their itch. So the first step in managing itch is to ask about it. In the clinic, ask your patient if they have itching. And if they do have itch, there's a simple question you can ask to sort of gauge how significant that itch is. And it's what we use in clinical trials. It's called the Numeric Rating Scale, or NRS. And what we ask is, in the past week, on a scale of 0 to 10, 0 being no itch and 10 being the worst itch imaginable, how would you rate your worst itch? And if the answer is 3 or less, then that would be no or mild itch, and most likely it's not significantly impacting their life. If they have an itch score, an NRS of 4 or greater, that would be considered moderate to severe itch, and we should really think about adding some therapy for it. Now, of course, we also want to talk to our patients about how this might be affecting their life, and itch can affect the patient's lives in many ways. It can interrupt their sleep. You can ask their partner if it's keeping them up at night as well. That's a frequent complaint we hear. Are they using different instruments or tools to scratch themselves? Oftentimes patients will underestimate their itch, but they'll be using all sorts of kitchen instruments to scratch their backs and otherwise. You can ask about the distribution of their itch. Is it in specific areas that might indicate a different cause of their itch, or is it universal, all over their body, a deep itch, or affecting the soles of their feet or the palms of their hands? And that's important to gauge because we know that as the itch worsens, patients can feel social isolation. They feel that they don't want to go out and socialize with friends or family. And this can actually lead to poor outcomes of these patients. So once we address the severity of itch, its impact on their life, then the question is, what next for treatment? And there are some simple remedies that are non-pharmacologic that we often attempt. Itch is typically worsened by heat and dryness. And so just keeping the skin moisturized and cool, taking cool showers, using minimal bedding, avoiding wool or scratchy clothing can sometimes alleviate mild itch. But talking to patients, generally these conservative measures really don't have a significant impact on the degree of their itch. For those patients, we're really talking about pharmacologic treatments. Now, historically for treating itch, we've used bile acid binding resins like cholestyramine. The data actually indicating that they are effective in alleviating itch is really scant, but we know these medications are safe. However, they're not very tolerable to patients. Patients frequently describe drinking cholestyramine, which is a powder mixed in a liquid juice or water. They've described it akin to drinking sand. It also has to be separated from other medications, in particular ursodeoxycholic acid, the common treatment of PBC. So then we're asking our patients to take medications up to 4 times or more a day, which then leads to lower adherence and just difficulty in managing that. So it has these problems of tolerability, frequency, and really poor efficacy in terms of treating the itch. So it's really not the go-to treatment that we've thought of in the past. Another common medication that we see patients prescribe, but for which there's really no indication, are antihistamines, hydroxyzine in particular. This is a medication that may be effective in some patients with PBC who itch, but their itch is from other causes, an allergic cause. It may also cause them to get sleepy, so they'll sleep better at night, but it's not addressing the underlying itch. We know that the itch of cholestasis of PBC is not due to activation of histamine receptors like in an allergy. Rather, it is mediated by what we call pruritogens that then activate the nerve endings in the skin and transmit a signal to the brain, activating that sensation of itch, which then can lead to the actual scratching behavior. And so we're trying to interrupt that pruritogen from activating those receptors or the signal going to the brain. So now our current therapies are really to try to remove the pruritogen by pharmacologic therapies. And the ones that have been studied the best and shown to be most effective have been the PPAR agonists. These are medications we've used for a number of years, including fibrates. And up to several years ago, a decade ago, bezafibrate, which is available in Europe and Asia and Canada, has been used in PBC, and it's been observed that it actually improves itch in PBC and other cholestatic diseases. More recently, medications including elafibranor and seladelpar have been studied for the treatment of PBC, not just for their improvements in liver biochemistries that are predicted to improve the outcomes of our patients in terms of clinical events, but also in terms of their ability to improve their itch sensation. And so in these pivotal phase 3 studies, seladelpar was able to demonstrate a significant reduction in the NRS score, that numeric rating score of itch, in patients treated with elafibranor compared to placebo. Now, this is looking at those patients that enrolled in the trial that also came in with moderate to severe itch, which was about a third of the patients. In contrast, elafibranor did not demonstrate a significant reduction in the NRS score, though there was an improvement in another measure of itch called the 5D itch. So there may be some benefit from elafibranor as well. In other cholestatic medications that are PPARs, including fenofibrate, have been looked at, but we really don't know about their ability to reduce itch at this time. There are other medications that work similar to cholestyramine in these bile acid binding medications by helping us get rid of bile acids in the feces. And these are called intestinal bile acid transport inhibitors, or IBAT inhibitors. These are currently approved for cholestatic conditions, including progressive familial enterohepatic cholestasis, or PFIC, and Alagilles. And they work by inhibiting this intestinal bile acid transporter so that bile acids are then excreted in the stool rather than being reabsorbed and circulated back to the liver. And so this reduces the bile acid load. And there is a phase 3 trial that just completed with linerixibat, which is an IBAT inhibitor. And it was studied in patients with PBC who had moderate to severe itch. And the results have been reported to be positive, and this is undergoing FDA review currently. And we expect that it may be available commercially in the near future, giving us another tool to try to inhibit or treat our patients with PBC who have significant itch. So in addition to these tools, there is evidence for a few other therapies that can be used. This is getting into the realm of data that is more anecdotal or case series. Use of sertraline, which is expected to block the signaling of itch in the brain, has been studied and shown some efficacy in patients. In the more severe cases of itch, plasmapheresis or other exchange approaches in terms of removing the pruritogen can be used, though this is really reserved for the most severe cases, usually while awaiting liver transplantation. And in the U.S., on very rare occasion, exception points can be allocated for patients with PBC who are suffering severely from pruritus. So in summary, we have lots of tools in our toolbox for the management of pruritus, both pharmacologically and non-pharmacologically. And these tools are increasing with the frontline therapies really at this point being PPAR agonists and likely in the near future IBAT inhibitors. I want to thank you for your time, and I hope this was useful for you.